I'm Dr. Mila Brujic. I'm joined today with Dr. Stephen Ferrucci, where we're going to be talking about those are some tight jeans on the OI show. Dr. Stephen Ferrucci, welcome back. Steve, if you could, just for the audience, please just give a little bit of a background on yourself, your practice setting, and also to kind of your areas of passion in optometry.
Sure, I'd love to, and thanks for having me again, Mile. So my name is Dr. Steve Ferucci. I'm the chief of optometry at the Sepulveda VA, which is one of the three VAs we have out here in Los Angeles. I've been here for about 22 years now. Also, I'm a professor at the Southern California College of Optometry in Fullerton, California. And yeah, I dabble in a lot of things, but really my true passion is posterior pole disease, retinal disease, unlike some of my anterior seg friends that I know and care about so greatly. But I do more retina care, and really my passion right now is with AMD as well as diabetic retinopathy. You know, what we can do to prevent it from getting worse, how we can treat it, how we can help our patients that have it, and that sort of thing.
It's great. Well, Steve, we're going to jump into that in just a second, but you have to share with the audience exactly what's so special about your hospital, in particular the way it relates to a pretty popular TV show that we're all pretty familiar with.
Yeah, so not so much now, but in the early days, it served as a backdrop for Grey's Anatomy. And in the first couple of years, they did all the exterior shots at Grey's Anatomy. So and I've met many of the actors on Grey's Anatomy. And funny story, they after they were filming for a couple months, and they decided they were going to invite all the doctors and staff for a lunch that they were going to pay for, and they showed us the pilot of Grey's Anatomy. So I'm sitting there watching it with a buddy of mine who's a primary care doctor, and I watched about 15 minutes, and I leaned over to him. I said, "This is the stupidest show I've ever seen. There's no way this is ever going to make it." Well, it shows what I know about Hollywood, right?
You just have that. You just have that eye for talent, Steve. I mean,
That's it. That's it.
it's a gift. You probably didn't want to invest in cell phones either early on as well, because that was just going to be a passing fad
Yeah,
too.
no, I'm waiting to make sure that and the internet. I'm still waiting to decide.
My oldest daughter is just absolutely super 100% jealous of you because she is a massive Grey's Anatomy fan. So Steve, let's start talking clinically about some of the stuff here. You got some really interesting things to share with us, in particular in the realm of genetics and how it's now affecting how we're assessing risk for developing macular degeneration, but also to risk of severe vision loss from AMD. So tell us a little bit about the technology.
Yeah, that's exactly right. As we know, AMD is a leading cause of blindness in patients over the age of 60 in the United States. And right now, they estimate about 11 million people have some level of AMD, and they say that's going to double to 22 million by the year 2050 as the population continues to age. So tons of patients with AMD. So there's a company out there called Visible Genomics, and it's one of two companies right now that has a test, a genetic test for AMD, the other one being Arctic DX. And Visible Genomics, they have two separate tests that you can do in patients for AMD. One's called the risk progression, and this would be a test, the AMD iGuard risk progression test is the exact name. This would be to do on a patient that has early AMD, early drusen and RP changes, what have you. And it would predict their chance for getting advanced macular degeneration. That would be either geographic atrophy centrally or choroidal neovascular membrane within the next 2, 5, 10, 20, or even up to 30 years. They also have another test called the lifetime assessment test, the AMD iGuard lifetime assessment test. And this would tell a patient that doesn't yet have the signs of AMD, but perhaps has a strong family history of AMD, what their chance of developing advanced AMD, either GA or choroidal neovascular membrane, over their lifetime. And we know from years of studying that AMD is in fact a genetic disease, and your genes actually give you about 70% of your risk for developing macular degeneration. The other 30% is environmental. So if we sort of know where we start, right, what your genetics are, it can help us predict what a patient's chance along with their lifestyle and other environmental factors that can help us predict what their chance for getting macular degeneration, advanced macular degeneration is.
Let me play out a scenario then here. So let me help us put this into clinical context. So let's,
Sure.
for example, I don't have a family history of macular degeneration, but I know that whenever we say that term to a patient, it is arguably one of the most concerning terms. I mean, whenever I bring it up into an exam room, you might as well have said cancer. I mean,
Right.
it's almost like they've signed off the fact that they are going to lose vision at some point. So let's say, for example, I'm a patient, I'm in your chair. As you can tell, I'm a healthy, young, studly 46-year-old male. But I'm concerned about my lifetime risk of
Mhm.
developing AMD.
Right.
I run the test and it says, you have a high risk of
Right.
vision loss from AMD. And I say, Steve, you tell me exactly what I need to do because I want to take my environmental risk and I want to drop it as far as I possibly can. So, with the compendium of knowledge that we currently have, what are those
Right.
recommendations, Steve,
Yeah.
for a healthy individual like me who doesn't have any signs of it, but
Right.
now I know that I have this high genetic risk?
Yeah, no, that's a great question. And like you say, I mean, you can't change your genes. So we're stuck with those. So we have to talk about the other things. So I would counsel a patient such as yourself, number one, the number one risk factor for getting macular degeneration, as well as having it progress, the number one modifiable reason, I should say, is smoking. So, number one, if you smoke, stop it immediately, right? Some of the other things we talk about are increased BMI. Being overweight has been shown in many studies to be probably the number two modifiable risk factor for getting AMD or having it progress. There's also things like UV protection, diet, exercise, and things like that. And plenty of studies have shown that a diet lower in red meat and higher in fish and chicken, as well as fruits and vegetables and that sort of thing, can help reduce the risk of macular degeneration. So I would counsel a patient like that, think about decreasing the amount of red meat you eat every week and substitute 1 or 2 meals of red meat you used to have with fish or chicken. That can make a meaningful difference. Also, the studies show that exercise, as much as walking a couple blocks a day, can even reduce your risk for macular degeneration. So it's not like you have to join a gym and work out and pump iron. I mean, even something as simple as walking can make a big difference. And then obviously UV protection, wearing sunglasses when you're outside, and things like that as well. So these are things that maybe the patient thought about, but now that you've given them, some active points to do, I think it really hammers the points home.
Steve, do we know what vaping kind of does as a risk factor or non-risk factor? Like, what does the literature say there?
Yeah, it's a good question. When they talk about smoking, most of the studies are slightly older studies. They're really talking about cigarette smoking, and most of them look at cigarette smoking. I have not seen, although someone told me there was one, but I have been unable to find it about vaping. The problem is, vaping somewhat of a newer thing, right? Within the last, I'm not really sure how many years. So I don't think we'll know the bad effects of it for years to come, right? Because these are younger people that are vaping. We're not going to know if they're going to get AMD for many years. But just from being a reasonable human being, it can't be good, right?
Yep, yep. Steve, another question too, and again, so this is a question that we commonly get from those individuals in particular that have a family history.
Hmm.
What about the computer screen? I mean, there's all this conversation about high energy visible light. I
Yeah.
mean, how much or how little should, in your opinion, and again, I know that there's a lot of information
Right.
that's out there, but in your professional opinion, how much or how little should we be concerned about this?
Yeah, I'm not totally blown away by the studies that look at blue light and macular degeneration. But again, these are longitudinal studies you would have to do for a long period of time in order to really see these changes as patients get older. So I think the jury's still out. We don't really know how damaging blue light and computer screens and iPhones and whatever will be in years to come. I think that remains to be seen. That being said, I've got two teenage daughters that are both on their laptops or computers or phones 24/7, and both of them have that blue blocking, or you probably know more about it than I do, but whatever it's called, in their glasses, because I figure, heck, it can't hurt for sure, right?
Yep. That's the interesting thing with it, and it's even difficult to communicate with patients because everybody's coming and asking about it. And
Yeah.
again, that's the caveat. It's not going to hurt you. And
Right.
it may, we're not sure, the data is not out because of all the reasons that you say, but it may
Yeah.
be beneficial. So, Steve, can you give us like maybe a case presentation where you've done the test on an individual who does either have early or intermediate macular degeneration, where now you're kind of seeing this individual and how maybe the information from the genetic test has helped you either stay the
Sure.
course or help modify the follow-up path, and how that looks different now for the
Yeah,
patient?
sure. So if I have a patient, let's say I have a patient that has some signs of macular degeneration. First I would explain to them there's a test out there, that genetic test, and we simply take a swab of your saliva, of your gum, your cheek rather, and we send it in, and it can let us know your chance of progressing to advanced disease within, as I said, 2, 5, 10, 20, or up to 30 years. Then I would send that out. I'd have the patient come back and go over the results for the patient. So let's imagine that patient falls into the moderate category, right? So basically, it's going to break them down into low risk, moderate risk, and high risk. And obviously, moderate it could be low, moderate, high, moderate, but basically those three. So if the patient's at moderate risk, I'm going to counsel that patient about certain things they can do to prevent it from getting worse, like we discussed with the lifetime risk, thinking about UV protection. If you smoke, don't smoke. If you're overweight, think about losing weight, eat healthy, UV protection, that whole thing. I also might start vitamins a little bit earlier on that patient. We know from the original ARED study, they don't recommend until you start those patients till they have intermediate or stage 3 AMD, but maybe the patient has stage 2, but they're at high risk or moderate risk. I might be a little more progressive and start the vitamins a little bit sooner in that patient. Also my patients with moderate or especially high risk, I'm going to see those patients more frequently, because we know from studies looking at anti-VEGF treatment in patients who have converted from dry to wet disease. We know that that the earlier we get these patients treatment, the better off they do at the end of treatment. The better the vision entering treatment, the better the vision exiting treatment. So rather than seeing this patient perhaps, every, 6 months or a year, if they're high risk, I'm going to say, hey, Mrs. Jones, you're at high risk. I really need to see you every 3 months, because if you do get worse, I want to know about it as soon as humanly possible so I can get you for treatment, because we know earlier treatment is going to benefit you in the long run.
Steve, what are you having these patients monitor their vision with at home? Are you having them use Amsler grids, or are you using some of these more advanced home monitoring systems, or maybe a combination depending on the level of risk those patients have?
Whoops. Yeah, yeah. So that's a great question. So I'm not a big fan of the standard AMSA grid. It's been around since 1941. It was discovered by a Swiss ophthalmologist in 1941, and I don't feel it's really good enough to check for early signs of metamorphopsia that might indicate conversion from dry to wet. And as I said, to me, that's one of the most important things we can do. So there's newer things like the 4C Home by Notal Vision that uses a preferential hyperacuity perimetry in vernier acuity to look for changes in macular metamorphopsia earlier. And they've shown studies that they actually can find patients who converted from dry to wet much sooner than just using a standard of care like the Amsler grid. So I think in patients with intermediate or worse, this home monitoring is a fantastic idea. And the other thing it has built-in compliance that a regular Amsler grid doesn't have, right? And let's face it, we've all given patients Amsler grids and say, do you do it? And they put it in the refrigerator and they never do it, right? But with the home monitoring, it goes into a reading center, and the reading center will see if there's any changes in their macular metamorphopsia. And if there are, they'll notify both the prescribing doctor, i.e., us, as well as the patient. Hey, Mrs. Jones, you had a change in your findings. You need to call your doctor. But the company itself can't bill for the service unless the patients do it a minimum 8 times a month. Right. So there's built-in compliance there. So if the company sees a patient's not doing it, their advisors will call the patients and say, hey, Mrs. Jones, we notice you haven't done the test. Is there a problem going on? Can we explain to you again how to do it? Or is there another issue? So it's that compliance, to me, as well as increased sensitivity, is a home run as far as finding early patient conversion.
That's great. The Amsler grid, Steve. I mean, people come in and they They say, yeah, I have it on my fridge. I said, oh, so do you put your reading glasses on when you do it? No, I just look at it straight up.
Yeah.
Both eyes
Yeah.
open? Yep,
Yeah.
both eyes open, just looking. I mean, it's just constantly
Yeah.
educating people how to use it. So we actually, we're looking into the notes all vision just so that we can be providing patients with other things now as well too. This was excellent, Steve. You're always a wealth of knowledge on posterior segment, in particular with AMD, and really kind of the new contemporary options in treating and managing these patients. Thank you, Steve, for sharing all of this, including the interesting genetic testing that we have available here as well.
You got it, my friend. Always a pleasure.
Yeah. And thank you all for joining us on this episode of the OI Show. Remember to subscribe to the podcast. And again, keep listening because every single week we have a new guest, just like Dr. Ferucci, that share with us the newest, latest innovations in eye care and optometry.